in many countries, many institutions, diabetic foot care is still fragmented, and lots of people just don't want to deal with it. And to me, that's a big opportunity because it's a huge problem. And so usually when you actually try to form a team, there's not that much resistance because nobody else really wants to do it.
This episode was made possible with the support of Medtronic Aortic. Aortic disease doesn't stop. Neither do you. That's why now, more than ever, we're committed to offering virtual education, off-the-shelf solutions, and unrivaled support. Medtronic Aortic, your partner in the evolving healthcare landscape, navigating change together. You're listening to the Vascular podcast from Radcliffe Vascular. Today's host is Professor Ramesh Tripathi.
With me today are two great proponents of diabetic foot, and not just proponents, but also people who have contributed majorly to diabetic foot care all across the world. I have Professor Joe Mills, who is John and Josephine Reed Endowed Professor in Surgery and Chief of Vascular Surgery and Endovascular Therapy at Michael E. DeBakey Department of Surgery, Baylor College of Medicine, Houston. He is also the Medical Director of Diabetic Foot and Wound Care Center at Baylor St. Luke's Medical Center. And with him is David Armstrong, who is Professor of Surgery and Director of the Southwestern Academic Limb Salvage Alliance, SALSA. He's at the Keck School of Medicine, University of South California, and he is the founder of DEFCON, American Limb Preservation Society, and both these guests of mine have won laurels all across the world, too numerous to count at the moment. So welcome, David and Joe. It's a pleasure to have you on my podcast.
Oh, Ramesh, I think the pleasure. I think I speak. Let me just take this opportunity to actually speak for Joe. But by saying it is our pleasure. This is really great to be here.
No, I know you both as friends, and it's nice to be together virtually to talk about something important.
Fantastic. So I understand that your collaboration goes back to your University of Tucson days, where you founded the SALSA, which was the South Arizona Alliance, and you became Toe Amigos and Flow Amigos.
It's well done, man. Hey, and what you guys can't see, actually, who are listening at home, if you subscribe to the podcast, is that Joe Mills is recording this using Zencast, and his handle here is Joe Mills Flojo. Not like Florence Griffith Joyner, but Flo Joe, like vascular surgeon Joe Mills or Joe the plumber. Joe, you want to tell the story?
Yeah, well, it's kind of interesting. So David was actually at our VA hospital in Tucson and linked with the University of Arizona. And I had met him as he was moving to be, I believe, an associate dean at the Scholl School of Medicine in Chicago. And so I didn't find out that we had such.
Yeah, I don't want to interrupt, Joe, but your memory is like perfect. Yeah, your memory is perfect so far. So please keep going.
Yeah, so I didn't realize how much our interests overlapped. So after a short period of time, I started looking for other opportunities, and I actually was looking at coming to Chicago to be at a different school, but I was interested in looking at building a combined podiatry vascular surgery effort with endocrinology to look at diabetic foot ulcer. And Chicago's an interesting city. It has a diverse population with many ethnicities. And I thought it would be interesting to be able to study access to care from different populations and different ethnicities. And I interviewed up there several times and finally decided not to come. And then not too long thereafter, David called me and said, what if I come back to Tucson? So I went to my department chairman and said, well, we want to build on this limb salvage service that we already have, but we can get into that later, but I really think we need to have foot doctors, not just blood flow doctors. And he said, sure. And then no one kind of knew what to do with podiatrists. So David ended up being part of our division. So that's how and then over a phone call, I believe, we came up with SALSA. We were trying to come up with an acronym, which became Southern Arizona Limb Salvage Alliance, which fits in well with the Southwest. And we spent, nearly a decade, more than a decade.
Just about. Yeah. Give or take, maybe take a little more than give.
Yeah. Well, I guess it's closer to 8 years. But anyway, and it's not as complicated as it sounds. We basically got some extra space that urology evacuated, and we had the vascular lab in one hallway, or in between, the vascular clinic in one hallway and the podiatry clinic in the other hallway. And we would just cross back and forth and meet patients and work together. And same thing with consults. We'd see them together. And we kind of, after working together for a while, started to change how we thought about the problem and how we thought it should be treated. But it was mostly by working together.
Yeah, and it's people talk about team science, team medicine, and it's easy to talk about, and it's actually hard to do. It's really hard to stick two different kind of surgical specialists on one team in real time, not only on an inpatient service but on an outpatient service, and we literally started in just the one hallway, and Joe and I, we would even share. This is back in the latter days of paper notes, believe it or not. But we started. We even shared a little like pull down table in the middle of the hallway, and we shared, I think, 4 or 5 rooms together, and we would be just doing curbside consultations with one another. And we had a little kind of Mason-Dixon line or Maginot line with a little tape down the middle where I would write my notes on one side, and then he would always kind of come over to my side like eminent domain, trying to steal territory. It was the Maginot line. I would say well done for you, because it's part of your court-ordered therapy to come up with good quality puns every now and then. And that was, I would say, on the SALSA scale of 0 to good, that was probably a 2 or 3 is good. I mean, it was well done for a first shot, Joe. Yeah, so there was a Maginot line.
No, but it was fun. We had a good time. And we actually, there was some resistance at first. The chief of orthopedics was one of my best friends, actually. And he called me up one day. And he's a great guy. And he called me up one day and said, "Why are you hiring this damn podiatrist?" And I said, "Well, he's really interested in has expertise in diabetic foot care, and we want to expand our offerings for patients with diabetic foot ulcers. He's not going to do trauma, and he doesn't want to do ankle reconstructions on athletes. He says, "Oh, okay, that's no problem." And it just points out that in many countries, many institutions, diabetic foot care is still fragmented, and lots of people just don't want to deal with it. And to me, that's a big opportunity because it's a huge problem. And so usually when you actually try to form a team, there's not that much resistance because nobody else really wants to do it.
Sure. And you guys working together showed that it made difference to the outcomes of diabetic foot patients. Yeah,
that's I guess maybe 4 years. Actually, I think maybe I think it was 4 years into it. One of the initial things that we did was try to kind of measure what we were managing. And what we saw was that when we put this team together, we saw a pretty dramatic change in the type of surgery that was done. And we had a movement away from kind of reactive and ablative surgery being most prominent and predominant toward more proactive and reconstructive surgery on the non-vascular side of things. So for instance, maybe more tendon transfers, osteotomies, skin grafts, and reconstructions versus amputations, urgent amputations, just as a percentage. We also had a dramatic change in the high to low amputation ratio at a center that was already doing really good work in the diabetic foot before this got started with Joe, because he had a significant interest in the area. So that was one thing that we saw for sure. In addition to that, Joe might want to talk about the fact that there was I know that John, our other partner, John Hughes, was initially worried that it would reduce the number of procedures that he was going to be doing. Don't you? Isn't that what happened? At first, we actually changed it.
Yeah, because our payment system is RVU driven, which is based on procedures. So RVUs stand for relative value units, and we'd built up a really successful limb salvage group that I was proud of, and we did a good job. But what I didn't realize until I started trying to expand was that you were only seeing patients that someone recognized there might be a blood flow problem. And there's a lot of other patients out there with diabetic foot ulcers and in whom the problem's not even completely recognized. It's just attributed, oh, it's just diabetes or it's just neuropathy or whatever. They never get a vascular evaluation. So I think if I remember the statistics correctly, over that second 4-year period, so we compared before SALSA to after, we ended up seeing close to 1,000 patients a month in the SALSA clinic between podiatry and vascular surgery. And our 2/3 of the patients required some revascularization during that time period, not always in the initial diagnosis and management stage, but at some point during that course. And then, well, actually, no, I'm sorry, it's about 40%, but 2/3 were endo first, which was pretty much in line with the rest of the world. But our actual vascular volume went up by about 70%. And then the reason was that a lot of patients would get sent with a foot problem to podiatrists, and we developed an algorithm where their flow status also got assessed, and we worked on together. And so it was, and the other thing we did, which I thought was really good, and we've replicated that to somewhat extent in Houston. I know David's doing that in Los Angeles, but when you get advanced vascular trainees working together with limb salvage and podiatry trainees, they teach each other. And they learn to work together and try to co-manage patients and talk about timing of debridements and how good is that revascularization and what should we do next. And it really cross-fertilizes the two training groups. So I think that may be the biggest gift we give, because that gets transmitted to the next generation. So hopefully we can encourage people to keep doing that.
That is for sure. And yeah, there was even a reduction when we measured that, the impact of kind of the toe and flow, if you will. On all this, what we found was that we even had a reduction in vascular surgery staffing during that period of time, and even with that, there was a dramatic increase in lower extremity reconstructions. Endo, as you heard, endo and open about 70-30.
Yeah, open went up even more. It was surprising because when you get a bigger population of patients, you get complex stuff that needs more than just endo sometimes too. So it was good for patients, but also augmented the practice.
And did you find that patients who had vascular compromise, if they had podiatry services earlier, it prevented further, major complications with the foot, even after revascularization?
The bottom line is that, when podiatry, I think the data now are pretty good that podiatry extends or kind of prolongs the life of the lower extremity, if you will. And what we see now is if someone has seen a podiatrist along with another member of the diabetes team, and it doesn't matter who that is. It could be a nurse practitioner, it could be an endocrinologist, it could be a GP. There is, in 1 year, there is a 6-year relative reduction in amputation, anywhere from just under 20% to just about 2/3, depending on what problem they have when they present, which is extraordinary. I mean, these numbers are extraordinary. The low end would be extraordinary. That first study was by friends of colleagues of ours at Duke. The Dukies. But subsequent ones have kind of said the exact same thing. And these have all been in one direction on that end. And then, of course, we know that taking care of the blood flow into the foot improves the life of the leg as well, and may even reduce morbidity and mortality. So putting them both together is really, really terrific. But Joe, why don't you speak to the primacy of podiatry's pivotal place in prevention?
No, there's no question. So before we worked with podiatry, we didn't do anything. We didn't identify high-risk patients by testing for neuropathy, unless they had a foot ulcer or if they had foot pain and only had neuropathy and had normal vascular testing, we didn't have much to offer those patients. And we didn't screen them by the risk criteria that the ADA or the APMA recommends. So basically, we were like our fingers in the dike with the water coming in. So we only saw patients that got admitted to the emergency room with severe diabetic foot wounds or infections, or the people that got recognized in the community that might be ischemic and got sent. So we were just putting out fires, and we still are doing that to some extent. But podiatry, as far as longitudinal management does, I mean, I think you need two things. We did really well with following the patients that have been revascularized. And initially, actually, I started out, I wasn't quite sure that David would have enough to do. So I had these patients saved up that I remember one in particular had a femperineal bypass that was probably 8 or 9 years out, was still widely patent, but he had a short transmat that I had to skin graft because he had an infection and his foot was in equinus. And when he walked, he kept getting a lateral foot ulcer. And I'd never done a Achilles tendon lengthening procedure, and I'd never done a tendon transfer. And so I had a handful of patients like that, and David started taking care of them. And pretty soon, actually, they started getting a lot of other referrals for foot problems. So there's no question that putting podiatry together with vascular surgery, most of what we do is totally complementary. So when we started out, we would still, before we had podiatry, we did all the toe amputations, all the INDs of feet. We'd take bad plantar fasciitis and treat it. But again, we're just treating the tip of the iceberg. And we still would do some of those urgent procedures before we recruited enough podiatrists. But increasingly, as your practice builds, you're busy enough doing the revascularization part. And it's really helpful to have people around that can help manage the wound, look at alternatives to closure, look at things like pan med head resection, which is an operation I'd never done before. There's actually a role for that. We'd never done prophylactic surgery in people with foot deformities to prevent recurrent ulceration. So there's a huge role for podiatry, and most of it is extremely complementary with what we offer. So before we had that, we didn't offer any of that. So we kind of struggled with these patients. And then we didn't have a high risk monitoring clinic. So when you get a number of podiatrists with trainees, they can actually see these high risk patients and monitor their foot temperature or monitor their activity levels, or put them in a gait lab and see where they're building up problems with their feet. And I think there's no doubt they can prevent some problems rather than just waiting for them to happen.
Yeah, it really, we kind of have a saying that hard things are hard, but just because they're hard doesn't mean they're not fun. And in fact, quite the opposite. And it's just putting this together and putting the when you put the team together and you put the effort into that, it's just, you get so much more out of it than you put into it. It's like it really is, it's extraordinary. And, I think I'm the luckiest toe doctor on the planet, getting to work, with all these world-class vascular surgeons. Of course, Joe being Flomigo Prime there, the kind of seminal one with whom I've had the pleasure of working. But, since that time now, it's just almost become, even though it's hard, it's become natural, not unnatural. And so what's so awesome, Joe sent me a text the other day because yet another group of folks that we had trained or had kind of set up what we call toe and flow shops together at another institution. Wasn't that just a couple weeks ago, Joe?
Yeah, so I'd forgotten about that fellow. Actually, that was about 7 years ago. But I know as a direct result of some of the efforts David and I have made that they have podiatry now integrated with vascular at University of California, San Francisco with Mike Conti. One of our former trainees at University of Washington went to a place that was run by orthopedics, basically, and they were experts on major limb amputations and changed the whole culture around. So he and Nitin Singh worked together in Ben Starnes' group, so they're a toe and flow group. University of Alabama, Birmingham has that. Larry Lavery's in Southwestern and works both with vascular surgery and plastic surgery.
What about Eric Liu in Chile?
Yeah, Eric Liu and John Merrick in University of New Mexico. So we get lots of phone calls, and you need to find. So not every vascular surgeon's passionate about limb salvage. I mean, all of us usually go into the field because we like operating everywhere. We like doing aortic work and carotid work, but if you look objectively at the population demographics and changes, there's way more PAD and CLTI out there than there are complex aneurysms or carotids that need fixing. So you need to have people in your group that are devoted to the limb. The same with podiatrists. Some podiatrists would prefer to do wealthy patients with foot deformities or do athletes. So you need to have both the toe and the flow components need to really be devoted to diabetic foot care. But if you do that, they can figure the rest out. And the solutions are pretty similar, but basically amounts to putting them either in the same division or at least in the same clinic, and you talk to each other a lot. That's the basic solution, basic recipe.
So Joe and David, if for our listeners, if somebody were to put a diabetic foot care unit together, what would you recommend will be the components of it, and who all should be involved?
Yeah. Okay. Well,
I know that flow part is there and flow part is there. What are the other areas that one has to look at?
This was one of the first things that we, when we got together, that we were really talking about and thinking about a lot, because we were asking was, because, Joe, I guess pre-pandemic, pre-apocalyptic, we would travel around the world quite a bit and see a lot of units that had different components there. But what we asked were what is the atomic minimum that you need to set something up? And you can be kind of agnostic to surgical or medical or sort of nursing specialty if you know the kind of key things that you need to do in managing the foot, and that could be when you're in a hospital and then when you're in an outpatient setting. We've actually written a lot of these things down. There's actually only 7 or 8 things that you really need to do, and if you check all 7 of those off the list, really, or 8, then you can have as few as 2 clinicians. That's that kind of where the toe and flow are kind of at the center, and you can have more than that. But it almost doesn't matter who is the team captain. It could be an interested physician, surgeon, nurse, therapist, physical therapist, or to translate Ramesh, physiotherapist, or whomever. As long as you check off the key components of things that you as a clinician need to do. I mean, there's certain things that need to be done. You need to be able to manage certain aspects of inpatient care. You need to be able to do a good quality surgical incision and drainage. You need to be able to assess blood flow and intervene endo or open or best medical therapy as necessary. You need to be able to keep someone in a euglycemic state whilst in hospital. I said whilst for you, Joe, because you think I'm cast.
It's your British affectation.
That I'm doing an affectation, and I'm not. But I just because I enjoy it. This is what we do out here in Los Angeles, Joe. Not there in Houston. So there are just these few things that can be done, and that one can check off the list. And once you've ticked those things off, you really have your must-haves and then nice-to-haves. And I will tell you, at the center of that is really what we call toe and flow. We've also added in our unit several other components, I'll say, and those key in those have been physical therapy. So we call our unit toe, flow, and go now. In addition to that, some of the great things we've added, I'll just say, and Joe can chime in too, because I know we've discussed this pretty recently at DEF CON, but we find that a lot of our patients, while we're treating them, are really clinically depressed. And I think we, if we're surgically or medically minded, we may not be as attuned to all of that as we could be. And, we try to get our colleagues in behavioral health and in psychology or in psychiatry involved. But, they're so busy, and unless someone is having a suicidal or homicidal ideation, it's probably too busy to get them involved initially. But what we have found is that getting our colleagues in occupational therapy involved, they are uniquely suited to be able to handle certain initial behavioral aspects and triage them as necessary. That has been wonderful in our clinic. In addition to that, nutritional services in the clinic, in our waiting area, actually talking to patients about diet and eating, and that has been an absolute a value added and plus. In addition to all of our good quality research that's going on, we have any number of studies that are going on at any given time. But that's kind of some of the key complements that we've had in our unit. I don't know if you want to add anything else, Joe.
No, I think the problem gets to be the bigger your team gets, the harder it gets to coordinate. So on the day-to-day activities, I think flow and flow can include, so it doesn't exclude other vascular specialists at all. So there are some vascular specialists who are vascular surgeons who are really devoted to the limb, and they're pretty expert both in open and endo. And there are others that have a moderate interest in it, and they're pretty good at open, but not so good at endo. So there's room for a cardiologist or interventional radiologist who's devoted to CLTI to be part of that group. But I think that's been shown in the BEST trial where they've gotten multiple groups to work together. But anyway, so in addition to that, the only thing we've added at Baylor is we have an infectious disease doctor who's really interested in diabetic foot problems. And we've tried to, we meet once a month and try to look at what antibiotic the patient was sent home on, if they really took it for the whole time, monitor sensitivities, and look at whether we're using the antibiotics appropriately. I think that's been helpful. It's still imperfect. I think ideally you'd want to have education nurses in your clinic that can help. I mean, because so what we've done so far is set up basically trauma centers for the diabetic foot. But the diabetic foot is a manifestation of a chronic disease that needs long-term management. So David knows this data, but there was a Stefan Moorbach paper not too long ago that looked at recurrence of diabetic foot ulcers in a system that has pretty good care for these patients. And it was 97% at 10 years. So these patients need long-term management. And I think part of that is controlling their sugar, monitoring their other problems with diabetes. And if you treat it like a trauma problem, you're not doing all that. So the problem gets to be, how do you put that together in your own center? But as far as managing the wounds and the high-risk patients, the two key components are toe and flow. And the other stuff you would like to have, I think Professor Bolton was the first one to call it metabolic. No, you need someone, either a diabetologist or an internist, to manage the diabetes aspect of things. And I think it does help if you could have dietary advice and lifestyle advice, if you incorporate that in your clinic.
And I didn't mention, by the way, I mean, it's almost like it's a foregone conclusion that we have good quality shoe specialists in the unit or very close by that can help. We have the great luxury at our place of being able to send our patients to one of our clinics at our National Rehabilitation Center at Rancho Los Amigos, which is kind of the world-renowned facility for rehab. And we have just a great clinic there, and a great center there for getting people into the right shoes and insoles and really working with them. But Joe hit on a key point, Ramesh, that we haven't talked about, and that was, that once folks are healed, they're not healed. At 1 year, with the best available data, about 40% are going to have recurrence. It's about 2/3 at 3 years and 3/4 at 5. And you heard talking about Stefan Moorbach's work in Soest, Germany, showing almost 100% recur at 10 years. So we coined the term many years ago, the remission. And just like, because we've often compared this problem to cancer, I'm sure you've heard that, us comparing the cost, the morbidity, the mortality to cancer. And it's not a fair comparison, but it's an apt one, because you can make an academic argument about it. Because and the other thing is, everyone cares about cancer, and not so many people care about feet, or not thinking about it, because it's this kind of silent, sinister syndrome.
And also the amount of resources that are thrown into it, with as much remissions and recurrences.
Yeah, that's Ramesh, you're exactly right. And so the goal then, when you think about remission, when you're talking to the patient, everything changes, right? Because when you talk to them and you can say, Ms. Garcia, thank God you're healed, but you know what? You're not healed. This is just like cancer. And you use the C word there, and you see Ms. Garcia kind of stiffen up, and you see Ms. Garcia's husband or grandson in the corner look up from their phone, and you say, this is going to shorten your life. This is going to shorten your life. And by the way, it may kill you. But here's what we're going to do. You are not healed. The chance is very high that in our long life together, that you're going to get another wound. It's almost certain. But what we're going to try to do as we work together is we're going to try to make that wound as unusual, as uncommon, and as uncomplicated as possible. You are in remission, just like with cancer. And then you see her kind of relaxing a little bit more, but kind of looking at you a little funny. All my patients look at me a little funny. Joe can confirm. Then we say we're going to get you in the right shoes and insoles. We're going to get you into the right exercise program with our physical therapy, getting out into remission. We're going to be counting your steps. And then you start to see them kind of saying, okay, there's something I can do now. And it becomes part of their life. And so instead of being 11th on their 10 most important things to do, checking it off the list, ticking it off the list, maybe it's like 9th or something, right? At least it's on there. It's on that list. So they understand this. And that idea of remission fundamentally changes everything, because then you start talking about ulcer-free days, hospital-free days, and activity-rich days. And then on the vascular side, it's the same thing. I tell every single one of our trainees, no matter what their specialty, I say, man, nothing ruins a good surgery like follow-up, right? And everything's going to go down. It doesn't matter what your specialty in surgery, and no matter how well you think of yourself, follow-up, either the patient's going to go down or the repair will. And that is true in vascular surgery as well. We can't confer immortality upon these patients. But what we see in vascular surgery is that there are now more revisional vascular procedures in many parts of the world than there are vascular procedures. And that means that these patients are in vascular remission. They're in ischemic remission, whatever you want to call it. So these two ideas of remission for these chronic conditions flow, if you will, really well together. And our goal, just as you heard from Joe, he equated it to trauma, which is great. Our goal, though, is to reduce the incidence of these and the severity of these acute on chronic complications. That's the big idea.
Yeah, when I first heard the cancer analogy, I didn't like it at first, but it's apt for a couple of reasons. Number one, the mortality for diabetic foot ulcers, especially with concomitant PAD, approaches most cancers except for lung and pancreas. But when you first give the patient that message, it comes across as negative. But I think the way you turn it into a positive, which it is that unlike some cancers where it's out of the patient's hands, really, there's not a lot they can do except wait to see if it comes back and monitor it. There are lots of things we can do with these diabetic foot patients to try to lengthen the length of their remission. And I think if you can sell that to the patient as a positive thing and get them actively involved in their care, that's one of the problems we found out with the research study we did with PCORI in our indigent patients from Harris Health is a lot of them had no idea that there was any link between diabetes and foot ulcers, and they didn't understand the link between foot ulcer and amputation. So educating patients that A, this doesn't have to happen, and B, it did happen, but it doesn't have to happen again, or at least we can try to push that down the road as far as possible. And the Japanese have really been the ones that have championed this wound-free period, which I think is a really nice endpoint to look at. Because if you just look at limb salvage, you can have multiple endo procedures and end up with a salvage limb for some of the high stage patients, but many of them still have wounds to deal with. So from a patient perspective, they really want their wound to heal because it means that they can have a little more freedom. They don't have to come back to clinic as much. But anyway, I think that conversation, although it starts out negatively and kind of almost predeterminism, if you will, but you can turn it into a positive thing and say, well, we have these things we can now do that may increase your time being free of this problem. It's still going to be in the background, but it may not have to come back in 5 years. Maybe we can make it come back in 10 years. I think that's that's a huge thing to do, is partnership with the patient.
The big idea, Ramesh, is that you're working together, and you're doing something. You're not backpedaling. This is so important. And again, the discussion with not only your patient, but to teach trainees this is having like expectations set, and maybe true when you're consenting someone for an urgent surgery or a not urgent surgery. But it's especially true when you're working with someone for their whole life. And when they see that you're going to go to the mat for them, and when they see that you're doing stuff with them and not to them, this seems like almost like it's just words, but I assure you it's not. It really matters. And they see that. It doesn't matter your specialty or generality. It's just the absolute truth.
One of the things I find is that when we are working as a diabetic foot team, patients come to the hospital and we look at their problems. But when they go out in the community, how do they maintain whatever advice we have given in terms of compliance and in terms of, not just their diabetic medication, but also their footwear and also exercise? How do we ensure that? And that is always a problem. Do you find that as well?
Hey, Joe, you want to talk about this? And I'll talk. We just had a paper. We just had an NIH study, a big one accepted today. But maybe Joe wants to first touch on this, and then I'll touch on it.
No, we have a different healthcare system than most of the world. So we have problems with getting continuity of care once the patient's discharged. So sometimes they come in, they're out of network, or they live too far away to make follow-up easy. And COVID helped here a little bit because the regulations on telephone visits and video health visits were relaxed somewhat. And we found a lot of patients really appreciated to be able to ask questions and have a follow-up visit, and even stick their foot up in front of their daughter's camera so you could take a look at it. And for a lot of patients,
we call that a foot selfie.
But it gave them reassurance, and it also helped us sort out like who really needed to come in. And then once our system got better at protecting patients and protecting ourselves, patients got more comfortable coming in. But I think for places that serve large geographic areas, it's a struggle sometimes to get patients back. So we've tried to do that. We have a big healthcare system that's now it started out as Catholic Health, CHI. Now it's Common Spirit, and there's multiple hospitals in the region, but we've still not successfully built mini toe and flow units, or, if you use the trauma analogy, you have level 1, 2, and 3 trauma centers. Ideally, you would have the same kind of thing for limb salvage centers where basic care was available everywhere, and then it would get stepped up depending on their Wi-Fi classification and what expertise was available at each site. That would be the ideal thing. And I think in some instances that's easier to do. Like the NHS has started to make some big steps working, and it's actually been driven by a couple of podiatrists over there, but to try to get access to care quickly for patients that are high risk.
Right. But on the adherence thing, Ramesh, I'll just briefly touch on this. It's really difficult. And we can only begin to understand what our patients are going through. And imagine if, most of our patients don't have what one of my mentors used to call the gift of pain, and so they may look like us and even dress like us, but they are probably not going to behave like us because they don't have that feedback. It's profound. And, even if they still have all of their executive function intact, even if they're not clinically depressed, they just don't have that nociceptive loop that we take for granted as human beings. And that changes you. And, Spinoza used to talk about, if you can touch it, you have to almost touch something to be able to sort of comprehend it and realize it, understand it and internalize it. It's the same thing. Yeah, you have to be able to, interact with the earth to be able to move through the world. And that you lose that balance. So there's that. And But how do we give patients sensation back when they don't have it? Well, we have to do substitutions. And for years, we've worked on various kinds of sensory substitution devices. We don't have time to talk about that. Maybe next time, Ramesh. But what we can talk about, though, is ways that we can ping the patient a little bit now using some very inexpensive gadgetry to get them maybe to know if they're kind of to get them to do what they know they should already be doing, and we know they should already be doing. And we have a study starting this next year, funded by our National Institutes of Health, where we are going to be randomizing people into a standard boot, which is removable, another boot, which is irremovable. We know that when we make things irremovable, that more people heal, but that's kind of punitive. And then the third arm, is going to be a patient group that has a removable device, but with a smart watch or just a system that's going to alert the patient when they're and the clinician when they're not wearing their device, and kind of give them a little bit of a nudge. And we're going to see how much that nudge works, and maybe figure out better ways to nudge them without just driving them crazy. And again, doing something with them and not to them. We'll see. I think we're going to learn a lot from that study, and it's just a super exciting time.
And you are also looking at artificial intelligence and biosensors to aid you in diabetic foot care?
Well, that's a great question. So there are a bunch of different AI overlays for a bunch of different things. Joe works with one of my former postdocs and who's now a full professor with Joe, and that's Bijan Najafi, who's been doing a great deal in activity monitoring. And we just collectively published a paper, I think today, in JAMA Network Open, looking at certain wearables with AI overlays for frailty. But we're doing this for thermometry, for skin temperatures. We're also doing it. I had mentioned with Joe the idea of this foot selfie, where we have patients just take a simple picture of their foot. And one of our medical students, third-year medical student with us here at USC, Mark Swerdlow, he's a great young man. And he 3D prints a little box that people can put their foot on and take the exact same kind of picture each time. And patients take their picture and it gets uploaded to for free, to a little server. And we review it every Monday at 7 a.m. We have kind of foot selfie rounds, and we can get through like 50 or 75 quick photos super fast. And man, Ramesh, not a week goes by without exaggeration where we don't stop a hospitalization or get to someone quickly. It's so simple and it's great. It's almost like chart rounds in a weird way, but it's just virtual, and that works great, especially peri-COVID. But people are taking this one step further, including us. We're trying to get a kind of a visual AI-based overlay to where we can have a kind of smart vision, be able to identify patterns that without human interaction, or maybe with a hybrid human machine interaction. And some of the people that are really leading the way are our friends in Manchester. It's being led by Moy Hoon Yap there. And Moy Hoon at Manchester Metropolitan is working with Oracle on that as well. It's called the Diabetic Foot Grand Challenge. And that's one of several groups that are doing it. But she's doing great. I'm really excited to hear what she's doing along with the group at MARS, at the Manchester Amputation Reduction Strategy in Manchester.
And David, is this technology extendable to dressings and topical applications as well on the ulcers?
Yeah, great question. Yeah, yes. The short answer is yes. The long answer is it's complicated, like everything. But the concept of pattern recognition this is what we do as humans, and we're good at pattern recognition. We've worked to develop machines that work on pattern recognition as well. And of course, one has to be careful. There's so many dangers with AI, with, depending on, you can get garbage in, garbage out, depending on what you put in on the input side. But if you're able to teach these networks appropriately, then I think you can really start on a pathway that's poised for success. And that could be based on various kinds of analytes you can measure in addressing, but it could also be, and definitely could be, based on patterns of activity. And that's super exciting. And thermometry.
Oh, that's great. Coming to Joe. Joe, what do you think about telling our listeners about your Wi-Fi classification and how it differs from class, and how we can improve the utility of Wi-Fi classification in daily practice? I've seen a lot of and read a lot of literature on Wi-Fi, and we try to apply it in our practice, but sometimes we find it's too cumbersome, and a lot of people have alluded to that fact to me. So how can you make it more user-friendly and improve its applicability?
Well, a couple things about that. So just as far as the development of Wi-Fi, I mean, when you're sitting in the trenches working on patients, you tend to rely on how you were trained. And when I started out, I trained with Dr. John Porter, late Dr. John Porter in Oregon. And most of those patients I saw with him were pure ischemia problems. And basically the problem was, how do you get more blood to an extremely thirsty foot? And I applied those principles for many years. And it took me a while to figure out that the demographics had changed. So we no longer had all the patients with diabetic foot ulcers didn't necessarily have recognized ischemia. And in some of them, it wasn't as severe as what we used to call critical limb ischemia. So it got hard to sort out who needed what. And so I was trying to think of a different way to think about it. And David and I started working together. And if you back up from the seeming complexity of it for a minute, on every single patient, if you're going to look at the limb, you want to stage it like you would a cancer, right? So the idea of Wi-Fi would be like TNM for cancer. So it doesn't stage the patient as far as their comorbidities, and it doesn't really tell you much about specific anatomy, but it does tell you about the risk of the limb or cancer and has it spread and how advanced is it. So if you think about it, on any given patient, I like to think in Venn diagrams, but you have a wound, you have ischemia, and you have foot infection. And some combinations are maybe more dangerous than others. And most vascular surgeons would agree that patients with diabetes probably need more blood flow to heal than non-diabetics, and would also agree that when you have some PAD that's complicated by infection, that may drive the need for revascularization, where the patient might not meet a certain hemodynamic definition of CLI. So if you think about it, you sort of have to assess the wound, the infection, and the ischemia in every patient. So the new app just came out. It's been improved from SVS, so you can plug all the descriptors in and actually get a Wi-Fi classification, so that it classifies patients into 4 risks. So what does that do? First of all, the class 1 patients almost always will heal with simple offloading and debridement if they need it, if they have a low-grade infection and don't need revascularization, and they're low risk for amputation at 1 year. And that's been confirmed in multiple studies. There was a meta-analysis done from a group from the Netherlands, published in the European Journal last year, of almost 3,000 limbs, and that there was 0% limb loss at 1 year in the clinical stage 1 patients, but it was 38% in the clinical stage 4. And then the 2s and 3s separate some, but not quite as dramatically as 1 and 4. But if you look at wound healing time, actually, that's been looked at by multiple groups. It separates them out. So to me, there's no question it's useful, and also that it helps drive therapy. So if you imagine if the problems that at the given time is mostly infection with less ischemia and not even that much of a wound, then the priority is on addressing the infection and then reassessing the patient. So the other thing about Wi-Fi is that you reassess the patient after a course of therapy, just like you would restage a cancer patient who had TNM at time 0 and then underwent a course of chemotherapy. So that's meant to stage the limb. And then the global guidelines came out last year, which I think both of you were involved with, but it was 58 authors from multiple countries. And it just tried to look at the perspective. So the idea behind calling it CLTI is it's a spectrum. It's not a single cutoff for ischemia, and lesser grades of ischemia that aren't quite severe may need to be corrected in order to heal a wound or keep it healed. So so the concepts that came out were to classify with Wi-Fi. And then the next concept that came out from that was called plan. So patient. So there's it needs to be improved to include other things like nutritional status and probably ambulatory status and frailty status. But the patient part was based on a huge BQI study that Jessica Simmons did that looked at perioperative 2-year and 5-year mortality. And we have pretty good data now to predict that in patients. And clearly patients with high perioperative mortality and limited 2 to 5 year mortality probably should generally be treated with endo because it's less invasive and durability is less of an issue. So that's the P part of plan, PL. And P plays as the patient comorbidity index or mortality index. L is limb, which is Wi-Fi. A is the anatomy, and that's where GLASS comes in. So GLASS was a new classification system to try to improve task, which has pretty much been abandoned. So GLASS actually looks at the target artery path that you would choose to get blood to the foot. So it's meant to be more applicable to endo, but it looks at limb-based patency and multiple stages of fempop and tibial and foot disease. And actually, there's some studies now. There's one from San Francisco. There's a couple from Japan. There's one from Europe that show that the GLASS scores correlate with limb-based patency and with limb salvage. So if you put GLASS together with Wi-Fi, it gives you a more evidence-based, logical way to look at these patients and not do the same thing for everybody. I mean, to say that endo is the choice of therapy for all patients with chronic limb-threatening ischemia is not true, nor is bypass. So it gives you a logical way to go through those patients. So I think there's also an app for that. So that app just came out. So you can actually, and that's where you mentioned AI. AI could be used, and there's at least one group doing this, to analyze angiograms and try to come up with the GLASS classification. So once we can validate it, so what if you had a low-risk patient who had a good vein, who had a clinical stage 3 or 4 Wi-Fi limb, who had a life expectancy that was reasonable, and you had data that showed that bypass was better for that patient based on their GLASS score, then you might choose bypass rather than just doing what you know how to do. So that's still in the works. We don't know yet, but it's broadened the way we think about these patients. And it takes away the argument of endo versus open. It tries to make it more like a menu that you choose the best option for that patient.
Exactly. And Joe Ramesh was also saying, well, it's when he's tried to use it in his clinic, it's been complicated. And let me just try to make it as uncomplicated as possible. Sure, managing these patients is complicated. I don't need to tell you that. I think I'm preaching to the converted there. But you disentangling all this stuff, you have that Venn diagram that Joe talked about that we had put together many years ago, back, I think, in 2012, 2013, when we were first talking about this before it was actually published as Wi-Fi. But you really just have to ask what's dominant, and so you look at the wound. Is it none, mild, moderate, severe, 0 through 4? Super easy to do. So that when you're looking at tissue loss, you look at ischemia, none, mild, moderate, severe, based on hemodynamics using the SVS classification that's been validated. Super kind of basic to do as well. And then finally, foot infection, none, mild, moderate, and severe, based on the IDSA classification. You put all those together, you have Wi-Fi, and it's easy, 0, 1, 2, 3. But when you're assessing a patient, you have to ask, what is the dominant condition? Is this an infection dominant condition? In which case, generally speaking, the infection takes primacy, Joe, over, as you say in Houston,
or we just say it comes first.
Yeah. Touche. But it takes primacy over the infection will take primacy over everything. When that's sorted out, or if it's an ischemia dominant condition.
That's not to interrupt you, but that's a frequent mistake, is to delay drainable infection because you haven't got the Dopplers back or anything. And you can do a bedside exam, and if you hear phasic Doppler flow between the base of the toes, the foot's probably going to heal, number one. But number two, you can certainly drain infection. And then that's one of the advantages of endo. So if you promptly address the infection,
Yes.
you have less concerns about your revascularization becoming infected if you can do it endovascularly. So then if the patient comes in septoid, maybe they have a white count of 18 and some pus in the foot and a cellulitis that's 4 centimeters beyond the wound, and you do a ray amputation and drain some plantar pus, and 2 days later the white count's down and the foot is clean, you can put that patient in the cath lab and revascularize them and get really good outcomes. The Clarici's group does that. Clarici and used to work with the late Dr. Foglia in Milan.
And now
they've been big proponents of that idea that you've really, but you've really got to address infection. I don't know how many places I've been where you'll get a consult late in the week of some poor patient that's been sitting there for 3 days waiting for their Doppler tests, and they have a foot full of pus. And so that's where the Venn diagram, if it's a dominant infection condition and it's drainable, that always goes first, regardless of the vascular status. And so then if they do have significant, if they have grade 2 or 3 ischemia, you can't sit on that patient for a long time. As soon as you've got things damage controlled and cleaned up, you need to go ahead. So that's where I think thinking in those terms helps a lot.
Right. And
if you have a giant wound without much ischemia, then you can figure out, like, if this is going to need a flap, I'm going to probably have to get an arteriogram because they're going to need to know their anatomy.
Then it's just a tissue loss dominant condition. It's a wound dominant condition, and that is an outpatient. That can be managed outpatient, and that's more of that's just the landscape.
Yeah. Then the pure ischemia then is someone with classic ischemic rest pain and dependent rubor, and they can't sleep at night for a month, and they've taken pain medicines, and their toes are kind of purplish, but they don't have a wound yet. That's a pure blood flow problem. So that patient just needs their flow addressed. So if you just think about those 3 scenarios, then a patient that stepped on a tack or a piece of glass or a needle and has a minimal wound on their foot and has gas in their forefoot, that's a bad infection problem, right? So that comes first. So if you take the 3 extremes and then imagine as you bring those 3 circles together, how they overlap, then it gets pretty complicated when they have moderate infection. Is it drainable or not? Kind of a medium ulcer, you might be able to get a transmit, and their ABI is 0.6. So that's where having a team really helps when you try to figure out how are we going to stage these things.
That's the secret, because then you're going about this systematically together, and maybe you're texting each other, or maybe you're around the patient at the exact same time, or often you're even in the same case sharing anesthesia. I don't mean like actually sharing anesthesia. I mean, you know what I mean.
That would be problematic.
That would be. But there you have it. I mean, and so this is what makes it terrific, because time is tissue, and that saves time.
And not just time is tissue, but timing of everything between tissue loss and ischemia and infection, and when to do what. And which one to choose. And you rightly highlighted that your Venn diagram really aids you into doing that.
There you are.
So it's been a pleasure to talk to both of you. And to round up, I want to know what awaits us in future regarding diabetic foot.
Well, I think this is perfect because we'll have 2 slightly different but complementary views. So I'm more of a systems person and a Venn diagram person, and David is more of a gadget and technology person, but I think both will be necessary. So to me, the biggest thing we can do is to try to develop algorithms of care and actually coordinate care based on evidence base, and using systems that classify the limb, that classify the patient, and classify the anatomy to get appropriate care, and then get that to work throughout hospital systems and regions. And then ultimately, we'll have technology will help us, and I'll let David get into that. But there's ways of monitoring conditions now. Temperature's one, pH of wounds, different constituents of wounds that could be done with part of a dressing, a smart dressing, those kind of things. But I think those will only work if we work out a system first where we have the patient managed correctly. And then ultimately, I mean, the biggest thing is actually prevention, right? How do we get people back to a lifestyle that doesn't cause a global epidemic? I mean, this epidemic of diabetes kind of snuck up on us. It's been going on for 20 or 30 years, as in contrast to the current viral pandemic, which came seemingly out of nowhere and taken over the whole world in less than 9 months. But it's still an epidemic of sorts. And so we need to respond to that. I think ultimately it could be a little bit like aneurysm disease. Since smoking has gone down, we have fewer aneurysms than we used to. I think if we can get people back to healthier lifestyles and better diets, that we can reduce diabetes again and have fewer diabetic foot ulcers. But anyway, for me, the answer is systems creation and coordinating care at multiple levels and integrating healthcare systems. And then David could probably address the technology part, which I think will definitely be important, but it's not the first thing we need to have.
And you're right. But to kind of riff off of that, I think just two quick things. The first thing is kind of measuring what we manage, just like you heard. And I think we've been preaching the concept of diagnostics and theranostics, kind of companion diagnostics and theranostics to go with tissue repair and wound healing and vascular disease, by the way, forever. And I think now these next several years are going to see really an awakening for things like if this, then this kind of therapies, where we can measure something in a wound and that will dictate what we use in terms of companion diagnostics. There are too many of these now to mention that are quite exciting. So that's first, and it's kind of the diagnostics and theranostics. The other thing that I think is just super exciting, and we've been doing it for a long time. We've talked about it a little bit now, but that has really been accentuated by the pandemic, is remote patient monitoring. We call it RPM. Like clockwork last year in even before the pandemic, I think it was in April, it was a really, I don't use U.S. healthcare and progressive very often, but I'm going to say this was extremely progressive. This last year, the U.S. had certain billing codes that allowed for payment for remote patient monitoring that would pay clinicians and hospital units, hospital districts for monitoring patients at home, which has never happened. I mean, it's awesome. It's making prevention pay. So many of the things that we have been working on for the longest time, things like thermography, things like, smart insoles and, textiles and surfaces, et cetera, now can allow us to be able to dose activity like we dose a drug, maybe at home, and have an early warning system at home, like you have a home-based security system. And we could be the fire department, and that could be the fire alarm. And then we could coax people maybe into being a little bit more, maybe a little bit better health economy.
Thank you so much. There you have it. To summarize the Shaolin Masters of Diabetic Foot Care. Can I call you both that?
There's a Shaolin temple right across the street from me here on Ventura Boulevard, right next to a fancy pet store and I think a marijuana dispensary called Buds and Roses. So yes, you may.
So to summarize both of you, I think the future belongs to algorithmic healthcare systems in the recognition, prevention, and management of diabetic foot problems, as well as measuring what and how we manage these systems, and also patient remote healthcare and monitoring. So with these words, I want to thank Joe and David for this exhilarating talk with me on this podcast, and thank you so much, both of you.
Thank you, Ramesh. It's been nice to talk to you from a distance, and David, of course, from less of a distance.
Well, listen, Ramesh, it's really, really such a pleasure, really.
You're welcome. Thank you very much. You guys have a nice evening.
Take care, you guys, and be well.
This podcast was brought to you by Radcliffe Vascular and is sponsored by Medtronic. To view the series, head to radcliffevascular.com/vascularpodcast. You can also find us on all well-known podcast platforms and follow us on Twitter @RadcliffeVascu. Thanks for listening.